So approach to abdominal distension. Every objective has its own rationale. And if you've been to some of the classes I've done, you understand why I'm going through this. Abdominal distension may indicate the presence of serious intra-abdominal or systemic disease, okay? But it's also a common symptom of benign disease, such as irritable bowel syndrome. So you see the way they've just stated it. So if I am studying for this exam, one medical condition I'm going to focus on, because the MCC is talking about it, is irritable bowel syndrome. I didn't decide that, this is what is going to happen. It's the MCC who have decided that you need to learn this. So abdominal distension may indicate the presence of a serious intra-abdominal or systemic disease, but it is also a common symptom of benign disease, such as irritable bowel syndrome. And I'm very interested to know even why they mentioned irritable bowel syndrome right from the word go. Then they go on to talk about causal conditions. And I've dealt with the issue of ascites in a previous class. So you can go to our YouTube channel and then go check it out. It's there. It's there. We've dealt with irritable bowel, we've dealt with abdominal distension in the context of abdominal distension. So you have things like exudative stuff like, ascites, and then transudative cause of ascites like portal hypertension. So if I was studying this for this exam, I'm going to make sure that I learn exudates, transudates. And then it also talks about bowel dilatation. So like as a result of adhesions and volvulus and paralytic causes of bowel dilatation like toxic megacolon, neuropathy, so like diabetics who have gastroparesis, all those things. And then abdominal masses, as well as irritable bowel syndrome. They mention it again. And then they also talk about organomegaly, like, hepatomegaly, and then pelvic masses like ovarian cancer, abdominal and pelvic mass. So if you are preparing for this particular exam and you get to this particular objective, what I need you to do is to make sure that you've mastered ascites, differences between exudative and transudative ascites, intestinal obstruction, both small bowel and large bowel obstruction, paralytic ileus, abdominal masses like hepatomegaly, splenomegaly, irritable bowel syndrome, and then pelvic masses like, ovarian cancers and the rest. So all these fall under this particular objective. So you realize that the way they've designed the objective, they don't design it as system by system, right? Rather, they design it based on approach to this, approach to that, approach to this, approach to that. That's why we also take our time. But then after that, we take our time and we ask ourselves, okay, where can we put this particular approach? So you realize that in MedCognito, we will put this under gastroenterology, even though there are some other topics which go beyond gastroenterology, like when we talk about ovarian cancers and the rest. So if you go to your gynecology portal, you will see that we've dealt with ovarian cancer there. You realize that we've dealt with, intestinal obstruction and all those things, right? And currently, we're also reviewing all the objectives again for our class. So that also gives you a little idea about what we're going to do. So because irritable bowel syndrome was stated in there, we're going to take our time to make sure that we go through irritable bowel syndrome thoroughly to make sure that we don't miss anything. So let's jump into it right away. So the key objective then is giving a patient abdominal distension, the candidate will diagnose the cause, the severity and complications, and will initiate an appropriate management plan. So with all the causal conditions we mentioned when we started, what you have to do is, if you pick abdominal hepatomegaly, you've got to diagnose the cause, the severity, complications, and initiate management. If you have somebody with intestinal obstruction, you've got to be able to go with the cause, the severity, complications, and initiate an appropriate management. If you have somebody with ileus, the same thing. In the same way, if you have somebody with irritable bowel syndrome, that's the same way you have to go around it. Doctors, please, are you following me? Because this is how you can map things in your brain so you can, get this exam preparation going very, very well for you. Okay. So the enabling objective is giving a patient with abdominal distension. And I said we're going to deal with irritable bowel syndrome. So whenever you see abdominal distension, just put irritable bowel syndrome there. The candidate will list and interpret critical clinical findings, including features of the patient's history and physical exam that differentiate ascites from the standard bowel or mass. As I said, we've dealt with this in the previous class. The underlying cause of ascites or bowel distension, okay? And the same way, you also have to look at it in the context of irritable bowel syndrome as well. And list and interpret critical investigations and imaging, including laboratory investigations and imaging, like liver enzymes, paracentesis, interpreting acidic fluid results, abdominal imaging, including 3 views of the abdomen, ultrasonography, and construct an effective plan of management, including initiating specific therapy in case of ascites, initiating specific therapy in case of mechanical and paralytic bowel obstruction, and determining whether the patient requires specialized care. And we've dealt with all this in your student portal, as well as in previous classes we've done like this for the whole population. Okay, so let's see how we're going to approach this irritable bowel syndrome concept. How are you going to diagnose the cause of irritable bowel syndrome? How are you going to determine the severity of irritable bowel syndrome? What are the complications of irritable bowel syndrome, if there are any? And what's the appropriate management plan of patients with irritable bowel syndrome? This is how you have to approach this particular topic when you're dealing with abdominal distension. So, what is irritable bowel syndrome? Now, in order for you to ace the MCCQE1, how are you going to pick up a case of irritable bowel syndrome? That is why I've highlighted the word recurrent. How irritable bowel syndrome will present in a board exam, as well as even in a patient who has come to you in the clinic. When you're done with your board exam and you go into your residency, is a patient who presents with recurrent abdominal pain. So look for that word, recurrent. Look for that word, recurrent, because that's very critical. Number 2, at least this abdominal pain the patient is experiencing is at least 1 per day, 1 day per week in the last 3 months. So I can say, oh, a 35-year-old patient has come in with recurrent abdominal pain in the last 6 weeks, and the patient experiences it once every week or something. I can put it like that. Now, the patient must have 2 or more of the following. Number 1, this recurrent abdominal pain should be related to defecation. That is when the patient is pooping. Or change in the frequency of stool, or change in the form or appearance of the stool. So a patient with recurrent abdominal pain at least once a week, which is related with defecation and frequency of stool, or defecation and change in the form of the stool, or defecation and or change in the frequency of the stool and change in the form. So you have to just look at it in the context of this. So I have a question for you. Since irritable bowel syndrome is very important and a high-yield topic you need to review, a 42-year-old female presenting with recurrent abdominal pain and changes in bowel habits consistent with irritable bowel syndrome, which of the following conditions is commonly associated with irritable bowel syndrome? This is the first question for the night. Which of the following conditions is commonly associated with irritable bowel syndrome? Number 1, is it type 1 diabetes? Number 2, is it psoriasis? Number 3, is it fibromyalgia? Number 4, is it osteoarthritis? Can somebody help me? What is your answer? So someone said fibromyalgia. Beautiful. I'm just checking the other answers others have provided. So a lot of people are going for C, 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 C. That's awesome. It's not A. It's C, fibromyalgia. Fibromyalgia. And the explanation is that fibromyalgia is commonly associated with irritable bowel syndrome. As mentioned, in the past, it is important to recognize this association as it may influence the management and treatment of patients with irritable bowel syndrome, fibromyalgia. Okay, so now let's do a CDM case then. I want somebody to read this case for us for a CDM case. CDM. Dr.
I can, doctor. A 42-year-old female presenting with recurrent abdominal pain and changes in bowel habits consistent with irritable bowel syndrome. Apart from fibromyalgia, which other medical conditions are associated with irritable bowel syndrome? List at
Beautiful.
least 4.
Beautiful. Please give me your answers. Because this is CDM, right? because the exam in the morning, it has MCQs, and in the afternoon, it has CDMs. In 2025, from April, CDMs will go away, and it will be only the MCQs. So apart from irritable bowel syndrome, apart from fibromyalgia, what other conditions are associated with irritable bowel syndrome? Do you know? Let's get into it. Other conditions which are associated with irritable bowel syndrome are: number one, chronic fatigue syndrome. And another name for that is systemic exertion intolerance disease. Chronic fatigue syndrome. So if you are looking for chronic fatigue syndrome in your exam and you can't find that name, but you see the name systemic exertion intolerance disease, it's the same thing. Okay. Another condition which is associated with irritable bowel syndrome is gastroesophageal reflux disease. Gastroesophageal reflux disease, GERD. GERD. Another condition which is associated with irritable bowel syndrome is functional dyspepsia. Functional dyspepsia. And then we also have non-cardiac chest pain. And then major depression, anxiety, and somatization disorders. These are medical conditions which are usually associated with irritable bowel syndrome. Doctors, please make sure you've written this down. Make sure you've written this down. Dr. Kadi says diabetes. So the Kadi, diabetes is not usually noted to be associated with irritable bowel syndrome. I'm talking about conditions which have been researched and known to be associated with irritable bowel syndrome. Okay. So please know this: chronic fatigue syndrome, gastroesophageal reflux disease, functional dyspepsia, non-cardiac chest pain, major depression, anxiety, and somatization disorders. Okay. Now, it's the same thing I've put here as summary. So when I'm talking about summary, I really, really mean something you need to pay attention to so far as your exam preparation is concerned. So just write it down. If you want to take a screenshot, that's fine with me. Okay. So how to pick up a case of irritable bowel syndrome? Number one, I said look for that patient who has recurrent abdominal pain, or it's been going on for some time. And then there's altered bowel habits. So if you see, that combination, you should draw attention to it. Now, features of irritable bowel syndrome. One of the features of irritable bowel syndrome can be pain. And how will the pain of irritable bowel syndrome present? The patient with irritable bowel syndrome, the pain of irritable bowel syndrome will present with cramping, and the intensity is variable. And there are times when there are periodic exacerbations. So look at it very well. Number two, the pain of irritable bowel syndrome is usually not in just one place. It can be in various locations of the abdomen. So look out for that in your questions there. Number three, the pain is related with defecation. And when I say it's related with defecation, it may get worse or it may improve with defecation. Irritable bowel syndrome. Number four, what are the factors that can exacerbate the abdominal pain? Because remember that we said up here that it can be periodic, right? So what are the things that can make that pain of irritable bowel syndrome worse? Emotional stress and specific meals. And we'll be talking about those meals when we get to the management of irritable bowel syndrome. And how come irritable bowel syndrome falls under the objective abdominal distension? Because it is associated with abdominal bloating, and there's increased gas production in the form of flatulence and belching. So look for that patient with recurrent abdominal pain at least once a week for the last 3 months. The pain is not in one specific area. It can be in various aspects of the abdomen. It may improve or worsen with defecation. Emotional stress can make it worse. Specific meals can also make it worse. And there's abdominal bloating. There can be belching. There can be flatulence. Okay. Now, another feature of irritable bowel syndrome, apart from pain, is altered bowel habits. And the bowel habits which are altered can be diarrhea or constipation. So realize that irritable bowel syndrome falls on a spectrum. The patient may have diarrhea or constipation, or the patient may even have diarrhea which alternates with the constipation. Okay. The patient may have diarrhea which alternates with the constipation. I don't know why my screen. Okay, good. And then there can also be normal bowel habits which may alternate with diarrhea and or constipation. So irritable bowel syndrome can present in various ways on your board exam. diarrhea alone, constipation alone, normal bowel habits with constipation, normal bowel habits with diarrhea, or diarrhea and constipation alternating. That's irritable bowel syndrome for you, how it will present. So now, I have another question. Can somebody read this question for us, please? I need a volunteer to raise the hand and then read this question for us. So we are immersing the questions, Dr. Samira, we are immersing the questions with the concepts. Please read the question for us, please.
Which of the following is not one of the subtypes of irritable bowel syndrome based on patients' reported predominant bowel habit? A is IBS with predominant constipation. B is IBS with predominant diarrhea. C is IBS with mixed bowel habits. D is IBS with alternating constipation and heartburn.
Beautiful. Please, everyone, give me your answer. Everyone, give me your answer. So, and let me look at the answers people are putting out there. The answers a lot of doctors are putting out there. It looks like the consensus is common, D, because we've talked about the fact that irritable bowel syndrome can present with predominant diarrhea, predominant constipation, can be alternating diarrhea and constipation, but then there's nothing like constipation and heartburn, right? So that is the answer. So irritable bowel syndrome with alternating constipation and heartburn, that's the right answer. That is not a common presentation. So the explanation is that the subtypes of irritable bowel syndrome with predominant constipation, IBS with predominant diarrhea, and IBS with mixed bowel habits. The option IBS with alternating constipation and heartburn is not a recognized subtype of irritable bowel syndrome. So please never get tricked in your boards, okay? It's not a recognized subtype, okay? So let's get into the historical features. Number one, we said the patient will present recurrent abdominal pain. Number two, while you're taking your history, you also want to ask whether there's any blood in the stools, because as soon as the patient says, yes, there's blood in the stools, you want to start thinking about other conditions apart from irritable bowel syndrome. As soon as the patient says there's blood in my stool, start thinking about other conditions apart from irritable bowel syndrome. What's the medication? When you're taking a case of irritable bowel syndrome as well, you also want to check for medication history. And there can be so many medications which can cause the symptoms of irritable bowel syndrome. So the diarrheal form and then a constipation form. So which medications can cause diarrhea? Antiarrhythmics like digoxin can cause diarrhea. Antihypertensives like ACE inhibitors can cause diarrhea. Statins, diuretics, anti-Parkinson's disease like levodopa. A medication like lithium, hypoglycemics like metformin, laxatives like lactulose, antibiotics like amoxicillin and magnesium. So I can even set a question from this end. Which of the following medications can cause diarrhea? And you should be able to tell me. And medications which can cause constipation can be anticholinergics, opiates, antipsychotic medications, and iron supplements. These are medications that can cause constipation. So when you're taking a history of a patient with irritable bowel syndrome, you've got to also get into the patient's medication history a bit. And then you also want to ask about family history of inflammatory bowel disease, of colorectal cancer, of celiac disease, because you want to rule out an organic cause of this presentation. It's after you've ruled out all those organic causes that you can settle and say that this patient has irritable bowel syndrome. So you've got to do your medication history, those medications which can cause constipation, those medications which can cause diarrhea, family history. If you see an issue of blood in the stools, start thinking about something different apart from irritable bowel syndrome. So, what about physical exam? Usually, physical exam in a patient with irritable bowel syndrome is normal. Normal. If you do the physical exam, everything is normal. Some patients may have abdominal tenderness on palpation, but for the board exam, a patient with irritable bowel syndrome will have normal abdominal exam and even normal general exam. If constipation, you may want to do a digital rectal exam, because while you are doing this physical exam, you're also looking for other causes of the symptoms the patient is presenting with, like organic causes, right? Okay, good. Now, remember that we said that the pain of irritable bowel syndrome can alternate, it can get aggravated. So what are the things which can make the pain of irritable bowel syndrome get aggravated? Number one, menstruation. Number 2, caffeine intake. Number 3, fatty foods. Number 4, stress. And number 5, sorbitol. Let me say it again. Menstruation, caffeine, so like patients who take coffee, fatty foods, stress, and sorbitol. These are the stuff or the features which can make irritable bowel syndrome worse.